Zakur's getting things organised, I will just emphasise that Zakur is doing this through some pretty tenuous connections from rural Bangladesh. The whole conference has actually been the parts that are from Bangladesh, not from Dhaka, but from BMC, where Zakur is a professor, and where all his students are. So it's quite a technical feat to get the feed working at times. But we've got a few contingencies if there are issues. But it looks like we've got video. We're just seeing if we can get the sound from Zakur there. I'll just see if I can get Zakur unmuted. So I'll just see if we can do that.
Hi, Bruce, are you here?
Yeah, we can hear you, Zakur. That's excellent. So just stay with that one, and we're right, I think. It is 8 o'clock, and we've got a lot of stuff to do. So it's with great pleasure. I'm Bruce Chater. I'm the chair of the Wonka Working Party on Rural Practice, Rural Wonka. And it's with great pleasure that I hand over to Zakur, who's the chair of the organising committee from BMC. Zakur, while we were coming in, I just mentioned that you're doing this from BMC out in rural Bangladesh, so we might have a few challenges along the way with the technology, but it all looks very good at the moment. And so I'll hand over to you, Zakur.
Well, greetings from Bangladesh. So I welcome you all on 17th Wonka World Rural Health Conference, Dhaka, Bangladesh, that is now live from very rural Bangladesh. It's 150 kilometers from capital and very rural setting. So may have some challenge. So we have very tight schedule with the 16th panel in our blueprint conference declaration Bangladesh 2021. I want right to start the blueprint. So all of you are welcome. 17th World Rural Health Conference, the conference declaration Bangladesh 2021, read by, this is Professor Dr. Zakir Rahman. I'm the organizing chair of the conference. The 17th World Rural Health Conference hosted in rural Bangladesh at the Brahmanbaria Medical College by Primary Care and Rural Health Bangladesh, and joined internationally through a virtual conference. Our FOMA has considered how best to ensure that high quality healthcare is delivered to the almost half the world's population that live in rural and remote areas. The conference was addressed by experts in rural health from all regions of the world. The conference heard of the substantial progress of rural health
I think we've lost Zakur there, so I might just keep reading for him until he can come back on. So the conference.
There is interruption with the broadband connectivity. Are you hearing, Bruce?
I can hear you again now, Zakur. So if you could start at the second paragraph, I've got that up for everyone to read. Thank you.
Okay. So the conference heard of the substantial progress in rural health in Bangladesh. We congratulate the government of Bangladesh for tremendous improvement of rural health care by establishing community clinics for every 6,000 people throughout Bangladesh. We also note that this and other measures have improved life expectancy and decreased maternal and infant mortality and narrowed the urban-rural gap. We acknowledge these achievements make Bangladesh an exemplar in LMIC and demonstrate that country's commitment to ensure healthcare for all people. But there is more to do to build on this in Bangladesh and worldwide. During this conference, we have clarified the key practical elements that can provide short and long-term change that will bring better services to rural people. We commit ourselves to this through a blueprint for rural health. This blueprint for rural health is designed to inform rural communities, academics, and policymakers about how to reach the goal of delivering high-quality healthcare in rural and remote areas most effectively. Introduction. All rural communities and the people who live in them need to ensure through electoral process, advocacy, and long action that their voices are heard and expressly and directly
Looks like we have a bit of difficulty again, so I'll just take over. So all rural communities and the people who live in them need to ensure through electoral processes, advocacy and local action that their voice is heard. Expressly, directly actions through proactive partnerships with policymakers, health professionals, academic institutions and health managers. Are you back on, Zakur? Rural healthcare needs. Primary healthcare, PHC in rural areas, should have the characteristics of being both primary in terms of including all first contact care, and comprehensive, local, grounded, and proactive in addressing the health needs of rural communities. Primary healthcare should address all basic healthcare needs, including community care, family practice, general practice, emergency care, preventative care and public health, and should provide timely access to maternity, surgical, sexual and reproductive, family violence and mental health services. It should be delivered as close as possible to the people, thereby ensuring equitable access for all. Rural services must provide first contact care and have suitable equipment for immediate care, including diagnostic imaging and point of care pathology. Preventative health, including health promotion, rehabilitative, vaccination and palliative services should also be included in the package of care available at the local primary care level. Zakur, are you back at all yet?
Yeah.
Okay, we're on to paragraph 3 under rural healthcare needs. I'll get back to you.
Yeah, I think it's done. So, rural PHC should, however possible, be enabled and enhanced by, but not substituted by technology, because it cannot fully substitute for emergency and procedural services. It has limited diagnostic capabilities and is not necessarily integrated into the local rural context, such as local referral and retrieval pathways. Universal healthcare is not possible without access to care. It should ensure that resources are not only available but can be accessed conveniently by all rural people, irrespective of their background, gender, and financial situation. Emphasis should be placed on engaging with and understanding the needs and health beliefs of historically marginalized population, including indigenous peoples, and respectfully informing them about their health, rights, and responsibilities. Local health services should be affordable to all. Primary healthcare in rural areas should be predicated on fit-for-purpose community infrastructure, education, employment, housing, clean water, sanitation, and sustainable energy are essential to this. Communities should be enabled and resourced to identify and address and indeed solve their local healthcare challenges. Developing a rural workforce selection, training, and support. Rural health workforce must be systematically supported and planned and have clear rural health pathways, often termed the rural health pipeline. Like a pipeline, it is important that there are no blockages within nor leaks from any of the pipeline elements. A comprehensive, complete, and place-based policy framework is required. Rural Lanka, working with the WHO, has developed 8 actions required in implementing rural pathways. We have referenced in number 4. The key elements to this comprehensive approach are rural health workforce should, as much as possible, be derived from the local areas that it serves. Grow your own. It should allow step-ladder progression of skills, attainment, and certification. Local health workers must be recognized as teachers by academic institutions, utilizing their services for their academic mission, respected for their contextualized knowledge, and supported to develop further their experience and expertise in teaching and stimulating learning. The community needs to be understood and the capability of local health workers and the scope of work established. To identify service gaps or sustainability issues that rural training and development pathways can support. So school students in rural areas should be actively exposed to, selected for, and educated in and for health science careers, understanding that students at all stages cannot aspire to a career that is not visible to them. You cannot be what you cannot see. The proportion of students with rural backgrounds in health science courses should at least equal the rural-urban ratio of the society. Students in rural areas should be provided with access to preparatory courses that enable students to enter health science courses. While prepared students in health science courses should also have rural impression that reflects the significance and importance of rural areas. All students in health science courses should have repeated and/or longitudinal immersion and learning in rural areas in at least the same proportion to population to ensure familiarity and comfort with the rural environment. They should be enabled, sensitized, and expected to provide culturally safe and competent care both as students and future practitioners. This should involve considering the various determinants that affect well-being and health, including culture, education, environment, and equitable development. Prolonged and repeated immersion in rural settings also increases the chance of finding a life partner with similar rural interests, and this contributes significantly to rural recruitment and retention, providing that the partners also have a meaningful life and work in the rural environment. Rural health careers should also be promoted, especially to young doctors, as a rewarding career where individual clinicians can really make a difference. Educational institutions have a social obligation to respond better to the health priorities for the benefit of every citizen living in the area they are supposed to serve. They must therefore orient their training, research, and service provision to privilege the underserved population living in rural and remote areas. Academic assessment must include examination in and above the rural context. It has been shown that this learning in rural environments provides a rich, passion-centered, and practical learning environment upon which academic learning can be scaffolded. Rural clinical learning is made more possible now with online resources and instruction. It more closely reflects the modern extensive research now confirms that rural clinical education delivers at least equal academic outcomes to urban-based coursework and the work-ready workforce. Rural coursework should ensure community engagement in health improvement initiatives and research guided by communities that foster and enhance rural services. Local research must be action-based, involve academic institutions, proactively assist in health service improvement, and should be guided by the community and its needs. Local communities should be provided with meaningful and local data and data analysis that allows benchmarking and facilitates action by local community and health professionals. For rural communities, there should be nothing about us without us. Regional teaching hubs should enhance but not replace the immersive rural experience and learning in smaller distributed communities. Rural training at the undergraduate, graduate, and postgraduate levels should be based on curricula that include rural context and include specific curricula for effective rural practice. Exemplary Australian College of Rural and Remote Medicine curricula. In family medicine, training should be aimed at producing rural generalists, family doctors who provide comprehensive, whole person, and continuous care in rural areas. This is supported by initiatives in rural midwifery and nursing and allied health profession and is applicable in the health professions. Policy and advocacy. Rural health services should be staffed by journalists or extensive staff in all health professions, each working at full scope of their capabilities in teams. The scope of health professionals can be expanded and enhanced by technology, including telehealth, but but trained health professionals are needed locally. Policy for rural health should include input from and decision by rural communities and rural organizations. Rural professional organizations should be encouraged and supported and should participate in decision making as key information about rural health. They should be equal partner in this process. Government policies should be assessed in terms of their impact on rural communities, rural growth to mitigate any deleterious effects of these in rural areas. Government should strengthen coordination and
The government should strengthen coordination amongst various departments and work
A plus
towards
multiplier effect on local opportunities, opportunities for economic development, and opportunities for individual progression, and improve opportunities for women in the workforce. They should ensure a sufficient health safety net that enable people to feel confident and safe in rural areas. Private and public providers should be encouraged to share facilities, resources, and staff. The aging population in rural areas means both an increase in healthcare workload and an opportunity to retain and employ a younger workforce to provide this. Sorry, my dear colleagues from different parts of the world, for hearing me, the blueprint. Sometimes we are facing the challenge in rural areas, that interruption. So please, developing versatile resilient teams by allowing for part-time and flexible working partners, which can particularly benefit healthcare workers with young families or portfolio careers, would enable greater participation. This could be supported further by developing a wider regional team through collaboration, particularly in specialist internist areas and continuing professional education. While not a solution in themselves, payment incentives to make a difference to recruitment, good management, with incentives. Successful recruitment requires intersectoral investment in training and career promotion. Successful recruitment requires intersectoral investment in training and career promotion, creating a desirable workplace and first creating and then incentivizing a pool of workers to make a longer term commitment to a rural area. These factors are all vital in attracting and retaining young doctors to rural areas. So many challenges. What's the challenge in case of COVID-19? The COVID-19 pandemic has shown the importance of local resources and self-sufficiency during a crisis and provides the rationale for major investment in local rural health service capacity. It has also shown that information, communication technology and effectively enhance rural health care solutions, situation and training, and rural health service delivery. What about climate change? The changing climate will put further challenges on rural areas, especially arid and coastal zones, making these less habitable or uninhabitable. It will also bring new diseases to some rural areas. These issues must be addressed. All my friends, in conclusion, Royal Lanka and the participant in this conference commit to actively adopting these principles and actions and calls on the World Health Organization, government, policymakers, academic institutions, and indeed communities in all countries around the world to honor their commitment to the rural population by providing fair and targeted health resources and opportunities for their rural people. We have 12, 15 references, and all these things are in screen as well as official reading. You show it on screen. Thanks, Bruce. Over to you, and now in for discussion with our panelists from different parts of the globe. We have plenty of strong panelists. Please, Bruce Chatter.
Thanks very much, Sakur. And we do have a strong panel, so we'll get straight on to that. Our panel each have 3 minutes to present, and they'll be actually responding to questions. So I'll just check to see if Professor Syed Modassar Ali, are you with us? He might not
So,
be. I
sir,
might
Professor
hold.
Ali is trying to connect
Right. I'll hold at the moment.
with
We'll
us.
move-
Please go ahead with the others. Here,
Do we have Manam Al Matab?
Good afternoon. I am here.
Governor Madhav is
Excellent.
hearing.
Excellent. Manam Al Matab is chairman of BSMMU, which is the large university hospital in Dhaka. Manam, I'd like to ask you, as a large university hospital in Dhaka, and yet you're a member of Primary Care and Rural Health Bangladesh, how can large universities like yours ensure that students come and go to rural areas? Could you just tell us a little bit about that in Bangladesh?
Bruce, thank you for giving me the opportunity. Currently, this is partly been implemented because the doctors in government service, the government health cadre, who come for postgraduate courses under my university, that is Bangabandhu Sheikh Mujib Medical University, which has many affiliating campuses all over the country, as well as a main campus in Dhaka. They all have to serve in the rural areas mandatory for 3 years, either before or while in the course. So if they have completed these 3 years of mandatory service before they join a post-graduation course under my university, that is done. If not, their course is suspended and they go back and do the job. But you have rightly said that that is one part of the story. But I am a hepatologist. So what happens to a hepatology resident without any exposure to the rural areas? So I think that's a very thought-provoking question that you have raised, where I cannot give you any straightforward answer, but I can assure you that we'll surely consider this when we review our curriculum, and at least in hepatology, I'll try to include it because it is very important, the rural exposure, because bulk of the patients from in our specialty also come from the rural areas, and health, hygiene practices, social cultures, taboos, etc. very important. So even a specialist hepatologist must be aware of the rural scenario in Bangladesh if he or she is to deliver proper specialist care to the people. Thank you.
Thank you very much, Manam. That's a very succinct answer, and we might come a bit further on to a chats for questions. So keep those questions, and we'll also like you to put them into chat. The chat will be recorded, and we can actually go back and answer some of those questions for you. But Manam, it's great to see a big hospital like yours supporting rural areas. Professor Sharmeen Yasmeen, are you with us? Maybe not. Nurul Islam, are you with us? Okay, we'll keep going down the list at the moment. We'll come back through these as we go. Kanabala?
Hello, can you hear me?
Nurul Islam. It's good to
Yes.
see you with us. Nurul, thank you for joining us. I'll just see if we can find you on the video feed here, but we can certainly hear you, which is good. Nurul, you've been a leader in South Asia for some years. You're fairly hard to miss with your bright orange hair at times and long white beard as well. You're one of the fathers of rural practice and general practice in Bangladesh. Could you tell us, please, what do you think are the opportunities that South Asia, in particular, you've been a president of MESAR. What opportunities should South Asia embrace in the blueprint?
Thank you, Bruce, to give me the chance to talk about where we are trying first to make the general practitioners, training for general practitioners was the our prime view to start with Onka, So the the 85% people of our area is living in the rural areas. So their care, their care, their facilities in the healthcare system still is not satisfactory. We are trying to train the doctors to come to the general practice at the same time to go to the rural areas to serve the people as per their needs. So our government also started the rural community centers in this respect. They started about 18,000 rural community centers for this purpose, so that the rural people can give, can have the health delivery system near with their hands. But we are need in trained people for the rural areas, rural communities, rural problems. So thank you very much. You are trying to give us some advice, facilities to train our people, to train our doctors, to more to give the more interest to the rural peoples, where maximum people lives in the country. So I also thank you, the people, that you have given the choice for a world conference in Bangladesh. So I am giving thanks to all organizers and the respected peoples related to the organization. And still, I want to give the thanks to the Jakur also, that he is from Bangladesh, taking the much more interest for this subject. And thank you very much for giving the chance to talk about. You will, I am seeing you after a very long period, after where we work together in Onka meetings. Thank you very much. Hope you live well, and hope to see you again if you get the chance on the Onka conference. If we get the chance to, and by this time we have lost so many, Anka presidents. We pray for them, for their safety, security in the life. Thank you very much for giving the chance. Hope you will be with us for future purposes. Thank you.
Thanks, Nurul, and that's very heartfelt. I think you make a couple of good points. One is that Bangladesh is still largely rural and needs that care. And the other really good point I think you made is that we need well-trained doctors, and I do thank Zakur and his team for providing that chance. Kanubala, are you with us yet?
Yes.
Yes, Kanubala, let's hear from you. You've been president of the Bangladesh Academy of Family Practice, so how do we? You're training this future generation of doctors. How do we get those young doctors out to rural areas? And is there any? Often in family practice, it can be private practice. How do we get the private sector and the government sector working together? Kanu?
Actually, private sector was neglected for last long years, and we established the College of General Practitioners to train the doctors, young doctors, for giving the interest for the general practice and general people. And we also have another institute, Academy of General Practitioners and Family Physicians. We have the two institutes in the private sectors to train the new doctors so that they get the interest in the general practice and give the service to the general people in the rural area particularly. You know, all biggest hospitals and all biggest specialists are living in the town area. So
Yeah.
the rural area is back. So we are trying to train the people so that train the doctors, young doctors, so that they get interested to go the rural areas and get them practice there and help the people there.
Thanks, Nurul.
And
Do you have a comment on that?
sorry,
Kanu, are you there? Kanubala?
No, maybe disrupted connection. You can ask Dr. Abu Said. Dr. Abu Said is with us, the very big
Okay.
man for rural health. And if Kanu available, I will contact with Kanu. Dr. Abu Said.
Are you there?
Yes, yes. Good morning, everybody. I am Dr. Muhammad Abu Said, Chairman and CEO of Raman Maria Medical College and Hospital. It's my great privilege and honor to welcome you all
Go
from
ahead, Abu.
Wanka Rural Health Conference. Actually, we are working to develop the health service in primary level, and we are trying to develop the family medicine also. You have done a lot. We all together are working. We have a large number of young doctors. We are trying to train them to serve the community for primary health care. And our Wanka rural primary health care, it will be a long step to develop the primary care service. Thank you all.
Thanks, Abu Said, and we're very impressed with all those community clinics that have been established. As we said in the opening, it's been an amazing effort to do that. Make sure that those clinics are within easy distance of the people that they serve. We've got a few younger doctors on the front line too. I think we've got, is Sarah Banu with us?
Sorry. Yes, we have got so many young doctors.
Is Sarah Banu or Nazeen Sultana or Fedos Malaika?
Yes, we have a large number of young doctors. They are also interested to serve in primary health care.
Would you like
Bruce.
to put any of them
Sir,
on?
with Brigadier Shofik, you can ask Brigadier Shofik. Brigadier General retired Professor Shofikul Islam. His principal belongs to Brown Boy Medical College. He is actually a trainer in rural area.
So that's Brigadier Shafiq Islam, is that it? You there? Ah, Brigadier, go ahead.
Thank you, dear, for giving me a chance to talk about the primary care, health care in Bangladesh. You know, our Bangladesh is a rural-based country. 80% of the population live in rural areas. So, to provide primary health care to those people who live in the rural areas of Bangladesh, our government has established health complex at Upazila health level, then union level, sub-center, and community clinics. With these community clinics, we are providing primary health care to our rural people. You know, a lot of doctors working in this establishment. So junior doctors are posted there. They are stay there and provide primary health care to our rural elite people of the country. With this effort, we are providing primary health care in our country, and thereby the health situation of the country has improved a lot. Our government is trying their best to provide primary health care to our rural people. With these few words, I like to conclude my speech. Thank you.
Thank you. Thank you very much, Brigadier. And I can see we've got Sharmeen with us now.
Sharmeen Yasmin, Professor Sharmeen Yasmin is public health specialist. He is current president of Public Health Foundation Bangladesh. You can ask public health related question to her.
Yes, thanks, thanks, Zakur. We'll hand over to Sharmeen. I've got a particular question for you about, Sharmeen, how do we integrate? We've heard a lot about the community-based primary care and how that's made a difference in these community clinics. How do you integrate public health with that? Is it something you see the clinics doing, or is it something that someone comes in from outside to do in those clinics? Can you talk a little bit about how public health is done? Thank you. You're on mute still.
Yeah, can you hear me? Am I audible to everyone? Yeah, okay, thank you. So I'm Professor Sharmeen Yasmin. I'm the chairperson of Public Health Foundation of Bangladesh. You know that in Bangladesh, we have lots of limitations actually. And our previous speaker has highlighted some of the facts regarding our country's situation. And but thing is that initially, actually, we had some problems with the readiness. And as you know, the Dhaka city, especially the cities, are very much densely populated than in comparison to rural areas. So most of our COVID-19 cases were actually held in the divisional city levels. And fortunately, in the rural areas, actually, we found less number of cases of COVID-19. But the fact is that maybe it may be due to actually lack of facilities for diagnosis in the rural areas. And the reporting cases was very much less at that time. But with advancement of time, actually, we installed some facilities for detection of cases, like detection by PCR test, and we have extended the labs in different divisions. Then from that rural area, samples were collected and diagnosis was done in those laboratories in the divisional levels. But in that time also, we found that the statistics in the rural areas were less in number. But what was the actual reason is that maybe they are, they are living in a low socioeconomic condition, and always there are some other vulnerable situations or risk factors among them. But in spite of that, we found a little number of cases, negligible number of cases. But, lots of people were coming back from the outside Bangladesh. They lost their jobs, who are working in the Middle East countries and some European countries. They came back into the country, and then they again remigrated to their original place in the rural areas. So from those people who have came back from the foreign countries by losing their jobs, from those cases, some of our rural people got the infection. So eventually our government took some strategies like rapid identification of cases and to isolate them and to make the people quarantined. But in the initial situation, the isolation and quarantine process was not that much organized. And so that the risk of transmission at that time was very much extensive. So then gradually our government took a very good strategy. They actually make functional the community clinics, then the union level and the Upazila health complexes. They place doctors there, and also community engagement was also held at that time, and it is also going on now. And now the current situation in Bangladesh is a little better than in comparison to other countries. The actually the number of cases is 400 to 300. It is ranging from 400 to 300 daily detection of cases, and it is 3% to 5% if we consider it in percentage. But but still the government is not declaring that we are in a controllable level, because we have lots of things to explore yet. So we think that in Bangladesh, in comparison to other countries, like we have done some control over the migration of people from outside countries to our country. Then also there are some detection of cases. It is also going on, and most importantly, the vaccination program is running very well in our country. It has also been started in the rural areas. The peoples are registering. In the first phase, 60 lakh people had been decided to vaccinate actually, and in the beginning there was some hesitancy regarding vaccination, but gradually when the people started to come for vaccination, then the people, even the rural people also, they were very much enthusiastic. Now the vaccination process is going on, so we are hopeful actually, if an integrated process we can continue in future, and even in the post-COVID time, things will come better. And I think it is not only the concern of Bangladesh. It has to be an integrated, it has to be an integration with all the neighboring countries and also with other countries. Because if one country is actually safe against COVID, it is not the conclusion for all, because we have connection with each other every day. We have a connection for business, for family purpose, and for every purpose of life, for livelihood. So I think it is an integrated approach we have to build up, and rural people should be taken care of mostly because they are always been neglected, and they are always been vulnerable to have any kind of infection, including COVID-19. So I want to stop here actually. So, but there are some possibilities also in our country in combating the COVID. We have seen that during the COVID pandemic period, our telemedicine service has flourished a lot. People from the rural area can get connected with the central area, and they are getting advices from the physicians, health experts, and other health professionals. So it is a very good, I will tell that it is a very good advancement for us. And also there in from the other possibilities, among other possibilities, we can say that our we have government has permitted for us rapid antigen antibody detection. So it will take less time to screen and diagnose the cases. And also people have started, also, there are some post-COVID complications, and people are dying from the post-COVID complications in our country a lot. So, and now people have started to treat and to follow up who have some comorbidities. They are coming to the hospital and they are getting the healthcare services. So there is the fear and the anxiety. These are being less now, and people are getting more knowledge about COVID-19 and more knowledge. But thing is that the practice of the health etiquettes, this has to be very much strengthened, using mask, maintaining the social distancing, and also the vaccination process side by side. All these measures should be taken appropriately. So I would stop here. Thank you so much for giving me the opportunity. I hope I will listen from some other speakers of this session. Thank you so much.
Thanks, Charmaine. And it does sound like you've been integrating, excuse me, the public health and those clinics together.
Yeah.
I know one of our speakers has to leave soon, and he brings a very complementary perspective, I think, from Africa. So Shabir Musa, who's known to many of us, is president of WONCA Africa region, coordinator of the African Forum for Primary Healthcare. I'd encourage you to join that. He's got some really great resources there. Shabir, you've heard what they've been talking about in Bangladesh and what they've been doing there. You've seen our blueprint as Rural WONCA for rural areas. Would you like to make some comments about how this or your reflections on this in rural Africa? Thanks.
Thank you, Bruce. Assalamu alaikum to all the participants, and congratulations to Bangladesh for hosting this together with the WONCA Rural Party. I think that it's a great statement, it's a great source of discussion. I think that in reflecting on the document, I think it's very relevant to all of rural Africa. As you can imagine, there is plenty of rural Africa that struggles with a lot of the issues that have been raised. I think that what I would like to emphasize, and that comes from my work in Afro-PHC, is the importance of us speaking to the whole team as the WONCA. I think that I even see a question here from Sankire Ephraim in the question, is WONCA only about medical education or for all health professionals? And I think that we are at risk of not showing the kind of leadership that is required of teamwork in the way we organize ourselves. And in Africa, we've actually taken a lot of the energy of WONCA Africa and taking and spending it in building up Afro-PHC, and it's developing an enormous amount of credibility, of goodwill, of actual teamwork. And I must say, this is not just, I think, just at a high level. I think it reflects in the ordinary practice of many of us that we do work with teams. But I think there's a certain level at which we suddenly become siloed at a global level. And I think there's time in Africa for us to all come together, and even at other levels. So thank you, Bruce, and all of you. I wish you well. I'm unfortunately have to leave at 1 o'clock my time, but it's really been great to be part of this.
Thanks very much, Shabir. And I think it's something we've taken on at our Albuquerque conference, that we have inducted some nurses into our Rural WONCA Council in recognition of that. And our Albuquerque statement was actually around nursing. And in fact, Shelley Nolan, who's just put up a note there, is one of the nurses on our council. So, and I think we've tried to reflect that in the statement.
Yeah.
So,
I think just a quick reflection in just a few seconds. I think that leadership is something, and in a nursing conference, I raised this, that leadership, if you have good leadership, and family physicians need to think about this, then a good leader makes everyone else leader.
Yeah.
So the role of who leads is actually a moot thing. And I think that we need to reflect on that. But at the same time, we need to realize that as a team, we have different accountabilities, and doctors have a strong accountability for clinical governance. And the team needs to appreciate that role, but that it doesn't equate to leading in all respects. And I think that's kind of postmodern thinking about what teamwork really means and leadership means. And we need to embrace that much better.
Thanks, Shabir. And I think we've also made the statement that everyone should be stepping up and working to their absolute maximum. And that will involve different leaders at different times. I'm conscious of our time, so I might, the broader team actually is reflected very much in the work of Towards Unity for Health, who've been our partner in the lectures. I think we've got Elsie Kaguli Malwadi with us, who's the Secretary General of Towards Unity for Health. So Elsie, would you like to comment on those particular things and about the social accountability that your organisation holds very dear to its charter? Thank you.
Oh, thank you very much, Bruce, and everyone. It's really a pleasure to be part of this panel. And I would like to thank everybody for addressing this very important aspect of health. Globally, it has been noted that 20% of the population is rural. But when you come to some countries, especially the low middle income countries, it ranges from 60 to 80%. So we have to address their issues, especially in health professions education. And I would really like to thank you because you've really addressed this in the blueprint. It's very important for us to actually immerse our students into rural health, because unless we train the health professions in the rural areas so that they know what is happening there's no way that they are going to meet the needs of these people. So for health professions education institutions to be socially accountable, rural health professions education should be part of their curriculum. And I like the way you've put it. Not only, even if they don't work in those rural areas, they will meet people from the rural areas wherever they work, whether they are working at referral hospitals, national hospitals, or working at academic institutions. They really need to know the needs of the rural people because they make up a very large part of our population. And the only way they can meet their needs is if they know what their needs are. And that means they should be socially accountable and meet the needs of those people. So health profession educators must make sure that their students are actually introduced to rural health, and not only theoretically, but practically, making sure that they are immersed in these rural centers, they are exposed to what is happening there. In most of the low and middle income countries, as our friends from Bangladesh have highlighted, the challenges there are different from those in the centers where they usually train. And most of these centers where we usually train the students are actually academic big institutions, referral institutions. So if we don't take them to the rural areas, they will miss out on those experiences. And they will miss out in seeing, when they see a patient from a rural area, they may not get their needs in totality. So thank you very much for including health professions education in that blueprint, because it's the beginning of the pipeline to producing a socially accountable health professions. Thank you very much. Over to you, Bruce.
Thanks, Elsie. And one of the really strong women that we had in our webinars is joining us tonight too, and that's Joyce. I think she's a popular pick at the webinars because she talked about exactly what you've talked about, the immersion of people in rural practice, not just visiting as tourists. Joyce, can you give us just a brief outline of the sort of things you do at Moi University in Kenya?
Yes, thank you very much, Bruce, for that. I'd like to just tell you more about our program. We have this program which is called Community-Based Education and Service. It's a mandatory program for all healthcare professionals who are trained at the College of Health Sciences. It constitutes 27% of the academic curriculum. And actually, we take our students, we give them both theory as well as field practical experiences. All in all, at the College of Health Sciences, we actually have 8 programs. These are the medicine, medical lab sciences, physical therapists, medical psychologists, BSc nursing, CHED, Bachelor of Dental Surgery, and of course the public health. Now these 8 programs are sort of trained using the IPE, which is the interprofessional education approach. And we try to make sure that they all appreciate one another as team players of a health team. They must all understand how they work together as a team, and we make sure that we actually follow the principles of multidisciplinary, interdisciplinary, collaborative, multisectoral, and of course, intersectoral. Now, the question of what is so special about this is that we try to get these students right from the start, from year 1, to appreciate each other as part of a healthcare team. And because of that, we expect them to actually learn from whatever activities that they are supposed to engage in. And of course, we are guided by the WHO PHC elements, and those are the frameworks within which our curriculum is